Welcome back. We're going to continue our conversation on the therapy of infectious and parasitic disease. Let's first talk about drug therapy for tuberculosis. TB is the leading cause of death worldwide, and we still have outbreaks here in the US. Even though we have decreased the amount of TB outbreaks over the last couple of decades, it's still really important for us as nurse practitioners and advanced practice providers to control and decrease the incidence of the disease. And this is done by treating tuberculosis effectively, minimizing adverse effects, and educating our patients about their drug therapy. Tuberculosis is caused by Mycobacterium tuberculosis, and this is a slow-growing organism. It's also known as a Tuberculosis. Infections can be limited to the lungs, but it can also move to other areas of the body and other tissues. In most cases, the bacteria is dormant, and the person that is affected with TB doesn't have any symptoms. But when the disease is active, the increased risk for morbidity is pretty significant. To treat active TB, we're trying to eliminate the infection and prevent a relapse. But we also are interested in preventing further development of drug-resistant organisms. And to do this, we have to kill the tubercle bacilli that are active and then those that are dormant as well. Drug resistance is a major impediment to the successful therapy and treatment of our patients with TB. And now we have a higher emergence of multi-drug resistance TB. And there is extensive drug-resistant TB as well. So multi-drug resistant TB is MDR TB, and extensively drug-resistant TB is XDR TB. Now, any TB that's resistant to both Isoniazid and Rifampin, which are the two medications that are most effective to use against TB, that is going to be considered a multi-drug resistant TB. XDR TB, that's extensively drug-resistant TB, and then we have a more severe form of MDR TB as well. And this is when TB is resistant not only to Isoniazid and Rifampin, but they're also going to be resistant to all the fluoroquinolines and at least one other injectable second-line TB drug, like amikacin, for instance. When a patient has multi-drug resistant TB, it really is going to greatly increase their risk for death, especially patients that have a co-infection of HIV and AIDS. Also, when we have multi-drug resistant organism, treatment becomes very expensive. One case of TB is about $18,000. However, if there's a multi-drug resistant type TB or an extensively drug resistant TB, this cost can go up to $294,000 or $694,000 respectively. So quite a considerable jump in cost of medication. So how are you going to acquire a resistant organism in the first place? It could be through contact with someone who has a resistant bacteria already. We're talking about resistant bacteria of TB. And maybe they've had repeated courses of medication therapy and it wasn't effective. Now, common causes of non-effective therapy has to do with if the provider has prescribed too short of a length of therapy, the dosages are too low, maybe the patient is not adhering to the therapy, or maybe that adherence is intermittent or erratic. But most importantly, if you are prescribing a regimen that contains too few drugs, you are going to be at risk for resistant organism and resistant TB. This is the most important thing. You want to treat tuberculosis or TB with 2 or more drugs. Okay, when you're giving what we call an anti-tuberculosis regimen, it has to have 2 or more drugs. Otherwise, it's not going to be effective. And you want the drug that's going to be sensitive to the organism. And so in this case, it's tuberculosis bacilli. Now, some drugs are especially effective against actively dividing bacilli, and then other drugs are more active against the latent or intracellular bacilli. And the chances of killing all the tubercle bacilli have to be there, right? So we have to give one that's going to help us with the active and one that's going to help us with the dormant as well. And we already know that when we use multiple antibiotics, it really is going to cover more of the antimicrobial coverage that we need, right? It broadens the spectrum. But it does increase the risk for superinfection as well. But with TB, that is not the case with multi-drug therapy of TB. The drugs that we're going to use for tuberculosis are selective for the organism already. And so as a result, even when we use it in combination, they don't kill the beneficial microorganisms, right? It keeps our natural flora the way it needs to be. And so it doesn't create this condition where we are creating super infection. So how are you going to determine the drug sensitivity? Again, we don't have resistance to 1 or more anti-TB drugs. This is pretty common. Then we can use what is the mainstay of TB treatment, what you can see on the right side of your screen. You get the diagnosis, you go into the intensive phase, which is 2 months of 4 drugs every single day. So you see these 4 drugs here. And then the continuation phase is 4 months of just using the 2 drugs. And so we have to make sure that this patient is continuing this anti-TB treatment for a very long time. And this is why public health nurses get involved, and you as a primary care provider may have to get involved and make sure that you're checking in to see if they are following their regimen. Now, in 2016, the American Thoracic Society and the CDC and the Infectious Disease Society, they published practice guidelines that we are still following for the treatment of drug susceptibility in tuberculosis. And so as you continue to practice and you are working with patients with TB, you want to go back to these guidelines and see, what is the most up to date so that you're following the latest and the greatest. Okay, so the 4 drugs that you need to use are Isoniazid, Rifampin, Parasitic, and we use ethambutol. These are the first-line drugs for TB treatment, and they're used in most of the treatment regimens. You have to know all 4 drugs. Okay. Now, there are other drugs that you can use, and they are also considered first-line drugs, but these are the 4 drugs I want you to know because this is usually what we go to first. But for latent infections, rifampicin is commonly used instead of using rifampin. So you might see rifampicin as well. For patients that are taking multiple drugs, rifampicin has to be used to replace rifampin and reduce drug interactions. Okay, so these are for the patients that maybe have other underlying conditions, hypertension, diabetes, Hep C. They are just taking a lot of drugs. You're going to go for rifampicin. However, rifampin should be used over rifampicin whenever possible. Okay, so for me, I just go for rifampin. Now, the second-line drug treatments, per the clinical guidelines, it's a little bit different. You can go to the second-line treatments, maybe if you don't have something that's available or there has been some known drug side effect or interaction. And these are the cycloserine, ethionamide, capreomycin, and para-aminosalicylic acid, or PAS. You can also use aminoglycosides, streptomycin, and amikacin. Okay. The fluoroquinolones can also be used. You can use levofloxacin and moxifloxacin. And sometimes we can go beyond that as well. I want you to know the first line treatment with the 4-drug regimen that's here on this slide in blue. With latent TB, there's about 13 million people that actually have LTBI, which is latent tuberculosis infection. And up to 10% of these patients will develop active TB at some point or another. And because it can become active, it poses a threat to infected individuals and then to people out in the community. So before starting your treatment of a patient with latent tuberculosis infection, you have to make sure that they don't have active TB. You've already ruled that out. And it's important because it's a treatment regimen of 4 versus 2 of the drugs. Remember, active TB, there's 4 drugs, and then latent TB, you're using only the 2. If you don't do this appropriately, you are promoting resistant bacilli and multi-drug resistance. So how are you going to exclude active TB? You have to complete a physical exam, get a chest x-ray, and sometimes you might have to order some other bacteriologic studies as well. You can also get a quantiferon, which is a gold standard of TB monitoring. The CDC recommends 4 different treatments for latent tuberculosis. Okay, some people will use just Isoniazid alone. Some people use Rifampin alone. Some people will use Isoniazid and then they'll use Rifampin, which we've noticed, right? But because Isoniazid plus Rifampin is so simple, meaning you can only get away with using 12 doses instead of like 270 doses. So then the chances that patients will complete this course is going to be better than just using Isoniazid alone. So initially, when you're trying to figure out what is best for your particular patient, you have to educate them and let them know that, hey, yes, you may be taking more than 1 drug, but it's going to be for a shorter term, versus, yes, you only want to take 1 drug, but guess what? You're going to have to be taking this for 9 whole months. Okay, so make sure that they're clear on this. And we are trying to, again, eliminate any dividing tubercle bacilli, and we are trying to help with the continuation phase of eliminating any other persisters, okay, or intracellular bacilli. We can also get vaccination against tuberculosis, and here in the US we don't promote that very much, but if your patient is coming from another country, they may have received the BCG vaccine, and it's an attenuated vaccine. Where TB is endemic, the WHO will recommend this vaccination, and they give it in infancy. And it's really to protect patients that will not have or don't have it readily, the treatment of TB. It's helping them against severe life-threatening TB infection. We don't give this routine vaccination here again in the US, and it's because there's a low risk for infection with tuberculosis, and we have protection against pulmonary TB in adulthood, which is pretty variable. However, again, it all comes down to history and physical exam. You have to know who is at risk. In terms of patient-centered care, I do want you to look across the lifespan and see what your considerations and concerns are, because that is how you are going to approach your patient teaching and your prescribing technique. Okay. For children, the first line TB drugs are approved for children as well, except for rifampicin. You do not give rifampicin to a child. If they're over 12, then it is approved. Under 12, please do not give it to a child. You can also use ethambutol, and it's really reserved for children older than 8 years old. For pregnant women that have TB or latent TB, rifampicin is the safest during pregnancy, and the CDC says that the benefits outweigh the risk for isoniazid, rifampin, and pyrazinamide, but it doesn't recommend rifampicin. Okay, and this is because we just don't have enough data, enough studies. Do not give ethambutol. It is a tetragen. With breastfeeding women, according to the CDC, it is safe to use isoniazid and rifampin. And it is encouraged to continue using this during breastfeeding. But the other drugs, the benefits of breastfeeding against any other possible risk to the infant, you have to really weigh that out. So you have to think, like, is it more important that the baby gets the breast milk, or is it more important that we have to pivot and use a different medication, but we might have to stop breastfeeding the baby. The amount of the drug that's excreted in the milk isn't sufficient enough for neonatal treatment against TB. So what this means is, like, just because you're giving it to mom and they're breastfeeding, it's not going to protect the child. It's not enough. Okay, so again, give moms isoniazid and rifampin. It is okay. And then for our older adults, there's nothing really different than how we prescribe for our adult population. We might have to adjust the dosage according to renal function, however. Here's another chart for you to take a look at to see what the major adverse side effects are. For the first-line drugs, it really comes down to hepatotoxicity. For quinolones, we have learned in general there's some GI intolerance associated to that. With amikacin, streptomycin, eighth cranial nerve damage, what that means is there's a risk for ototoxicity and nephrotoxicity as well. Okay, I just want to focus in on the major players, okay? So we're going to focus in on isoniazid and rifampin. And isoniazid, it is the primary agent for treatment and prophylaxis of TB. It, as far as the mechanism of action, it suppresses bacterial growth because it's inhibiting the synthesis of mycolic acid. And mycolic acid is a component of the bacterial cell wall. And because mycolic acid isn't produced by any other bacteria, this would explain why isoniazid is very selective for tubercle bacilli, because there's nothing else that's going to create this mycobacterial cell wall. So if we can stop the synthesis of mycolic acid, we can help eliminate TB. Okay, and it also is very, in terms of, what is bactericidal and bacteriostatic. It's bactericidal to the microbacteria, right, to the mycolic acid, but it's also bacteriostatic to the latent or the dormant organisms, or the latent and dormant TB. When we use isoniazid, we're using it to treat active TB or latent TB. There's no other time where you are going to use this medication. And it has to be in combination with at least one other drug. Most of the time it is rifampin. Please note also that it does inhibit, and it's actually a strong inhibitor of the cytochrome P450 isoenzymes. You can see the different preparations. As far as pharmacokinetics, it peaks in 1 to 2 hours. It does cross the blood-brain barrier, and like we've seen in previous slides, it has hepatic metabolism, but excreted through the urine. Okay. For fast acetylators, it will have a half-life of an hour or less, and for the slower acetylators, it's going to take up to 2 to 5 hours to reach its half-life. Again, the adverse effects here, it's hepatotoxicity, but you will have peripheral neuropathy in some patients, so allow them the understanding and the education for that, and they may see some CNS type issues that could interfere with their optic nerves and cause optic neuritis, seizures, dizziness, ataxia, and even some psychological disturbances like depression, agitation, loss of memory, and in severe cases, hallucination and toxic psychosis. So it is a big deal to go over the adverse effects and to make sure that they understand this. And you can see that there's so many different ways to dose this medication, and most of the time, if you are having to dose this medication and it's not something you're actively doing or you don't see a lot of TB patients, you're going to bring out the clinical guidelines and make sure that you are following it correctly. But they do have, and you have, the choice of daily, 3 times a week, twice a week, or weekly. There are some preparations where you can actually have fixed dose combination capsules, and they're sold as Isoniazid and Rifampin. And you are going to get in this preparation 150 milligrams of Isoniazid and then 300 milligrams of Rifampin. And then there's other tablets too with different milligram preparations of these drugs. So reviewing the key prescribing considerations, you're trying to, as your therapeutic goal, cure the disease and make sure you're not only achieving the elimination of active, but also the latent tuberculosis. Make sure that you have some baseline data that you are providing, so you're not just saying, I think you have TB and you're going to give it, because remember, this isn't like a broad spectrum antibiotic that can treat many things. It's only treating TB, so don't give it unless you know they have TB. So you might have to get a sputum culture. You might test for the susceptibility of isoniazid, get an x-ray. You might check liver function tests, because remember how it is metabolized, and get a complete physical assessment. In some cases, you might get quantiferon as well, just to make sure. You have to monitor these patients because they're on these long extended treatments. Make sure they're not getting any of the adverse side effects, especially the more extensive and life-threatening ones. You're checking for any risks. Is there a contraindication? If the patient has acute liver disease or they have a history of isoniazid-induced hepatotoxicity, you can't use it, right? And we need to use it very cautiously with patients that are drinking a lot of alcohol, they have diabetes, or they have a vitamin B6 deficiency. Other patients that are older 50, we are watching as well. And then if they're in any other of the medications that are listed here, you are just going to create a system of a tighter follow-up for these patients. How are you going to know if it's working? Well, they should have a reduction in their signs and symptoms. Reduction in fever, malaise, anorexia, cough, night sweats, all the clinical manifestations of TB. If you get a repeat chest x-ray, you should see evidence of improvement. And if you get another sputum culture, you should have sputum in the absence of tuberculosis and the bacilli. Minimize the adverse effects. Okay. Now, some people will use a prophylactic pyridoxine, 25 to 50 milligrams a day, because it can decrease the risk of acquiring a peripheral neuropathy. Now, some people do it and some people don't. You have to identify who is going to be more at risk or who might need this. So if they already have diabetes, then I may order this too, because they have an underlying risk of peripheral neuropathy already. Okay, so take those things into consideration if you want to dosed prophylactically. So rifampin is not less popular than isoniazid. We have to use them both. It's equally as important if you're trying to get rid of TB, uncomplicated TB. And it is one of our most effective anti-TB drugs that we can use secondary to isoniazid, or like in conjunction with, okay? It is bactericidal, so it's working at the extracellular and intracellular level. And it is a treatment of choice for treating pulmonary TB and the disseminated disease itself. Now, the mechanism of action is different than isoniazid. With rifampin, it's going to inhibit bacterial DNA-dependent RNA polymerase, and by doing this, it's going to suppress the RNA synthesis. By suppressing RNA synthesis, we are suppressing protein synthesis. Therefore, it is bactericidal. It is also a powerful inducer of the cytochrome P450 enzymes and the CYP1A2, 2A6, CYP2B6, and so on and so forth here. So you want to make sure you understand it is an inducer of the cytochrome isoenzymes. Rifampin is in capsule form, but you can also get IV preparations to reconstitute. The pharmacokinetics is just a little bit different than isoniazid. It is peaking at 2 to 4 hours. Again, it is widely distributed and crosses the blood-brain barrier like isoniazid. The half-life, however, is 3 to 4 hours. Hepatic metabolism this time is eliminated by the feces and the urine. Most people tolerate this drug okay if you're giving it at the recommended doses, but you're still looking for hepatotoxicity. Sometimes it does cause your urine to look a little bit red-orange. People will also note that their sweat, saliva, and tears look a little bit red-orange because of this medication, but make sure you know and that they know it's harmless. Okay, it's just something they may see. They will have permanent staining of contact lenses if they put their contacts in, because their tears can turn this color. So if they're like 1-a-day contacts, it's not that big of a deal, but if it's their like monthly contacts, you might want to warn them. And then the dosing here, like isoniazid, there are ways to dose this daily, 3 or 2 times a week, and even we can give this to children. It is not recommended though for weekly administration for either adults or children. The key prescribing considerations of rifampin and the other rifamycins are pretty similar to your considerations for isoniazid. You are going to get the baseline studies and look at the baseline recommendations. Make sure you're monitoring that they are not having any of the adverse side effects, and you want to make sure that they're taking it as prescribed. Patients that are high risk, again, like if they're taking in lots of alcohol, they already have an underlying liver disease, or they're taking warfarin, you're just watching. Make sure you are evaluating therapeutic effects. This is exactly the same as you would do with isoniazid. And going back to the contact lenses, because of that red orangey color, make sure that they know this, and they might just want to put on their glasses until their treatment is over. But just like you saw earlier in the chart, treatment can last a very long time. For patients that are on warfarin, it doesn't mean that they can't be on this medication, but you want to monitor their PT and INR very closely, and you might have to adjust their warfarin doses. You also want to inform your patients that are on birth control so that you can perhaps consider non-hormonal birth control instead.